And welcome back. Dr. Christopher Nin is with us again. He's been on our show a couple times before, and it's always a pleasure to see you. Welcome.
Thank you, Ken.
It's great to have you here. And you are a orthopedic surgeon and sports medicine specialist. You work out of two locations. We had one up there, Pacific Coast Orthopedic Institute, but also the Chapman Orthopedic Institute, and you have your own locations as well. But there you oversee the programs there, right?
Correct. I like to impart information to our guests regarding, non-operative treatments and also later operative treatments, but really how to take care of their joint pain.
That is great. And obviously you specialize in these state-of-the-art joint replacements, but prevention is the key, right? Try not to get injured. Let's talk about a little bit what causes the different types of joint pains that people have. Yes, there are people who have arthritis and things like that. But are there, when one know the difference between, I went out and I was mowing the lawn and, tweaked my shoulder versus this might be something I need to have checked out. I think that a lot of people, they'll just let it go. Well, it'll work itself out after a while.
Right, so in terms of joint pain, now we have kind of the acute pain where you can have an injury, you can have a tear. Mm-hmm. Tears are very common in the knee, meniscal tears. And meniscus is basically a cartilage cushion for your knee. And if you have a little tear, a rent, it causes a sharp pain, twisting, turning. It's like a rock in your shoe. Mm-hmm. Now that's a very easy problem to fix. We use minimally invasive techniques in which we do arthroscopy, in which we make little portals, little holes, smaller than my fingernail, go in with the video camera, and we clean it out. Very minimally invasive. You walk right away. 15-minute procedure, and patients do amazingly well.
Is this cartilage that builds up, or
it's
calcium?
Cartilage that's torn.
Okay.
And it's like wear and tear of your knee. I always compare it to like a tire in your car. It's like you can run over something, get a little rip in the tire, and then the tire doesn't run well and it hurts. And so we clean out the tire, kind of shave it so it's smoother, so it can ride well. Same thing with your knees.
Okay, and that would be obviously a minor operation, right?
Very minor. We don't open any structures. And then we don't. So it creates less scar tissue. And again, the portals or the holes are tiny, smaller than my fingernail, 4 millimeters. And the camera is that small. And the crazy thing is that you can see everything. With a camera, I can go around the whole joint, see everything better than when I open. When you open the knee, you create bleeding and scarring, and you can't really see much as opposed to the arthroscopy.
What about non-operative options? Is that something for if you have a minor tear or something like that?
Sure. So now partial tears, especially in the shoulder, can heal on its own, also just stay the same, remain the same. They don't progress necessarily. Okay. So if you have partial tear in your rotator cuff, that's the band of muscles that help you shoulder move. It can heal and kind of just be there without causing problems. You can do physical therapy. You can do injections. Sometimes it flares up, so you can have an injection, cortisone or steroid, and that really helps with the pain. But the thing with steroids is not good for your body. It thins the tissue and cause further damage long term. So you don't want injections all the time.
Right.
More than 3 a year is a lot. More than one time in 3 months is a lot. So you got to be wary. It feels good, but it's not a cure. So injections will help you with the pain, gets you in therapy, gets you going, but it's not a cure.
And what happens if these techniques don't work, these non-operative?
Exactly. So we can have the arthroscopic minimally invasive surgery. For shoulder, that's really all you need in terms of rotator cuff. Studies have shown open versus arthroscopic or long-term is the same, but better recovery, faster recovery. Patients do really well. And in my hands, because I'm an arthroscopist, I do only minimally invasive. I never open up the shoulder. And so patients actually do better because, again, it allows me to see the joint better with video cameras, better than my natural eyesight.
And I know this is something that you specialize in. You brought a couple models here, hip and knee. And I think I've mentioned before to you that I know somebody, my brother-in-law, who had a hip replacement. He did this up north. And he said it's just worked wonders for him. And from him, I understand it takes maybe about a year to really, where he gets fully used to it. And he has told me that there are times, especially up in the Bay Area, it gets colder, he'll feel it. He'll feel the coldness of it, but they said that passes after a while. So explain the joints you have here and the material that's used, and I find this fascinating, the way they are put on.
Right. So, so the total knee and total hip replacement have really progressed in the last few years. I mean, now the anatomy, I mean, this is called the get-around knee. It's better in terms of better function. The plastic insert here between the two metal components, I always refer to as like teeth. We kind of can cut the bone, shave the bone. We match the size. We put the metal implants over it with cement, okay, and then it cements on, okay.
Wow.
And then you put the plastic insert in between, and the plastic insert now it's cross-linked, so that means it's more durable.
Okay.
Before it used to be not cross-linked, now it's cross-linked, so now it lasts longer. Studies have shown it's lasting 20, 30 years, but we can't say that now because they haven't been in patients that long.
Yeah.
But the simulation studies are remarkable.
Wow.
Now, not only the implants are better, but the techniques are better. I'm a sports medicine fellowship, so I do everything minimally invasive. I like to muscle split. And with the newer hip technology, we're able to do what's called a minimally invasive technique in which I do an anterior muscle splitting. So I don't cut the muscle, okay? I split the muscle in the front. And this allows better recovery, less bleeding. Patients are able to get up the next day. Before, most of the procedures were in the back. So what happens was a lot of muscles were cut, and patients were walking more with a limp, and then you always had to have hip precaution. That's mean you can't sit and bend because you're always worried about dislocating.
Right.
When we do the incision out in the front, you can sit better because nothing posterior has been compromised. And not only that, we do it under X-ray fluoroscopy. So the implants are in perfect position, great position, because we can see it. Before we were doing the back, we didn't do it under fluoroscopy, and we couldn't tell the leg length, we couldn't tell the anatomy, and we had issues technically with putting in an implant, but now it's all under vision. And the reason why we're doing that, because the new implants are smaller and more curved, and also we have a special table that allows the hip to be distracted and use hydraulics. We use the newer technology to help us in terms of access to the hip, and the incision is only this big.
Wow.
Okay, 4 inches to 5 inches for most all comers, because 300-pound person, 200-pound person, we're all kind of the same in the front. We have the interval where it's not back. Most of our muscles in the back.
Right.
So that's why we can do the small incision for both bigger people and smaller people.
Wow, that's amazing. And as I said, my brother-in-law got this done up north, the exact same procedure. I think it was like in September, October, and he just loves it. And he did do something one day, I forget what it was, but he actually kind of fell. He almost like did the splits. The ground was wet or whatever it was. And he was worried, and he goes, wow, it was fine. Right. And so I can tell you, I know somebody who had this, and I think he's probably, I don't know, he's about 45, 48, something like that. Right. And had problems for years and just loves it, so it does work. Tell me about the material. Is that titanium?
So this is cobalt chrome.
Okay.
So it's a mix of like metal.
Okay.
And it's strong and it's durable. And then we have sometimes titanium stems, and that helps. But it's basically metal. And now it's always metal and plastic in between. They used to do metal, but there was problems with that. But metal and the plastic now is so much better. And we use sometimes ceramic, which is smoother, so it lasts longer. So your brother-in-law is lucky in the sense that the newer technology will hopefully last his whole lifetime.
Yeah.
And that's the goal. And so it's a great time in which newer innovative techniques, newer technology are getting people back to higher function, happier and pain-free. And the success rate for total hip and 90 to 95%.
Wow.
The best. And hip
That's
replacement
amazing.
surgery, patients do amazing. And there's studies out there that their quality of life in terms of points, I mean, it's amazing.
Yeah. And what about the possibility of the materials that are used that one's body may have a problem, reject it? You often hear that you get certain types of things put in,
Right.
and there might be an adjustment, or the body may reject it.
Reaction.
Yeah.
Yes, and so that was a problem more with metal implants. They had metal that were grinding. They had little metal particles, and people would develop reaction. That's on the out now. No one really puts metal anymore because of those problems. And you wear jewelry. Your wife wears jewelry. So most people don't have reaction to this inert metal, because if you're able to wear jewelry and don't have a reaction, you're okay. And then there's other implants that have a special coating that the metal is not exposed.
Oh, okay.
If you do have a metal allergy. So we have that option available.
Well, last time you were on, you were talking about setting up a seminar, which you have done. And this seminar is just about a month from now. It's on April 28th, and it's going to be held just down the street. It's at an area, it's called the Pacific Hills Banquet Facility, but it's right off of Lake Forest. It's not far from here at all. Tell me about what you're going to have in this free seminar and what's going to be going on. You're going to be talking about these different joint replacements.
Yes, so there's vast information. I wish I could tell you all about what I know now, but I can't. But we're going to have some time in which we're going to delegate to really informing patients about non-operative versus operative treatments and giving them good information about how to take care of their joints. And so I'm an educator. I love to teach, and I love to really impart knowledge out there so people can have an idea of what's going to not be too scary. Scared about everything. So I'm excited. We're going to have a series, and in the first session we talk more non-operative stuff in which we can prevent a lot of the joint pain.
Yeah, that is great. And again, that's going on April 28th at Pacific Hills Banquet Facility, which is really right down the street. It's near the corner of Lake Forest and Moulton, and it's an area that's they do all different kinds of banquets there. There's going to be a complimentary dinner, and it's free parking. Goes from 4:30 to 6:30. And if they want to join up, I have your phone number is 949-398-7800, and also they can go to your website. Correct.
Correct.
For both places, they can go to just think Dr. Nin. That's what it is. NINH, drNINH.com. That's where they would sign up for this.
Sure, yes.
Okay, and we want to encourage people to do that as soon as possible because these type of things fill up and they're obviously at limited capacity.
Right.
But I think it'd be very good for people to go to, especially this first one where it's just about preventing some of these joint problems that we may have.
Options before total joint.
Yeah.
Total joint's a great surgery, but again, it's the last resort.
Yeah, very good. Well, doctor, it's been a pleasure seeing you again, and I love that you brought on these models. It's fascinating.
Thank you, Ken.
We'll see you. I'm sure we'll see you again soon.
All right.
Take care. We'll be back in just a moment.